right, so most of you know who I am. Unlike what some of you might think, I actually don't do robotics for a living. This is what I do for a living. I do what's called interventional cardiology. We're going to talk a little bit about how I chose that field, why I chose medicine, what is interventional cardiology, how is that different from being a surgeon. After this talk, you will no longer call me a surgeon, you'll call me an interventional cardiologist, which in some ways might be a little superior, but you'll find out. All right, so about me, I went to Las Gatos High School. Actually, I've been all over. I've lived in Texas, I've lived in California. I actually went to high school in Southern Cal, came up here and went to Las Gatos High School because the school looked pretty. After that, I went to Berkeley. I was a double major. I got my bachelor's in molecular and cell biology and psychology. So I know a little bit about the human body from the molecular standpoint and a little bit about the human body from a psychological standpoint. So I know why half of you are a little screwed up. But let's talk about that. I went to University of California, Irvine for my medical degree. I went to the Mayo Clinic for Internal Medicine residency, and then I did my fellowship in cardiology in Baylor. Okay, now people have asked me, that's a long road. And why would anybody choose the field of medicine when you have to go through essentially 4 years of college, 4 years of medical school, 3 years of residency, and then 3 years in general cardiology, and then 1 year in interventional cardiology fellowship? That's a lot of school. I've had a lot of people tell me, dude, that's a lot of school. Why would you do that? Is it the money? Is it the prestige? Is it the fact you get to help people? The truth is, you make more money doing a lot of other things. You can help people in a lot of different fields. So if you don't have a passion for medicine, you really shouldn't do it. It's really, really a bummer to do all of this years of training if you don't have a passion. It's got to be a calling. It's got to be something that you feel like, you know what, this is something I really can feel myself doing. Even the boring parts, I can feel myself doing that, okay? There is a caveat though. It sounds like a lot of school, and it really kind of isn't. 4 years of college, yes, that's a lot of school. Double major, that's a lot of school. But the school you do in college is a little different from the school you do now. The school you do now is kind of this 7 to 3 p.m. existence, day in, day out classes. College is a little different. All your high school teachers tell you, they say this, oh, college is much worse, college is much worse. I actually found college in some ways a little bit easier because you only had 2 or 3 classes a day, right? The teachers expect more of you. There's less homework. So if you kind of don't decide to do the homework on your own, you might get homework like once a week, right? As opposed to every day like you do now. But the difference is in college, they kind of expect you to read it on your own and do more homework on your own if you need it, okay? Med school, the first year of med school was like a mixture of college and high school combined. You had classes every day from 8 to 5, and one midterm in med school was like the amount of material as a final in college, okay? So it was more material the first 2 years, and then the second 2 years was the best part. So the other part of this talk is you're going to learn a little bit something about me. When I was in high school, before I was in high school, my burning desire was to be a doctor like my dad. That was my burning desire. And then my version of high school rebellion was, I'm never going to be a doctor, I'm going to be a lawyer. I'm going to put criminals in jail, that's what my job was going to be. I did mock trial, did speech and debate, I did theater for a while. I had no science-related activity at all in high school, not even a little bit. I think I was in the Bear Academy of Science, but we didn't have robotics, we didn't have all these things back then. I didn't even volunteer in hospitals. And then right when I'm choosing my degree, choosing what I'm going to major in, I sat and thought about it for a little bit. I said, you know what? Here's the problem with law. And if you're a lawyer, great, wonderful for you. It wasn't for me, and I figured something out about myself. I found out that when I got home from mock trial, my little brother would say something off to me, and I cross-examine him like he was a witness. I'm like, no, I asked you a yes or no question. I want a yes or no answer. And I was kind of a dickhead. I thought, well, this is how weird I was. I said, the problem is if I became a lawyer, I probably would take that stuff home. Now, most people who are my lawyer friends are not like that, but I would take that stuff home. I'd be so argumentative, I'd probably never be able to stay married. At least when I'm a doctor, I'm supposed to be a nice person. So that's how I chose medicine. It was totally arbitrary. I said, you know, if I need to change my mind, it's not a big deal, but that's the field I'm going to go for. So I thought psychology, molecular cell biology, 2 things I don't do anything with now. Neuroscience is major, actually, so I studied a lot about the brain. So I thought to myself, when I got to med school, I'm going to be a primary care doctor. I'm going to be like an internist, family practitioner. I'm going to take care of coughs, colds, back pain, things like that. And for the first 2 years of med school, I told everybody that. Now, the first 2 years of med school are the hardest. That's school. The second 2 years, you actually hang out in the hospital a lot. There is no schooling. All you do is you do first 6 weeks of internal medicine, 6 weeks of surgery, 8 weeks of pediatrics, 8 weeks of psychiatry, all the different fields. And the surgeons ask, hey, Quan, you seem to really like surgery. Don't you want to be a surgeon? I said, nah, I'm going to be in internal medicine, all the way. 4th year med school was the best. 4th year medical school, you got to choose whatever elective you want. You do radiology, psychology, surgery, orthopedic surgery, cardiology. And I called my dad one day, he was an internist. He thought I was going to go into practice with him. That didn't happen. And he said, I said, Dad, I'm not doing internal medicine. He said, what are you going to do? I'm going to do critical care medicine. I said, critical care, why would you do that? I said, well, I love physiology. I love the fact these patients are dying, and if you don't do the right thing at the right moment, it's super dramatic. Like 80% of them are dead unless you do the right thing. And if you understand the physiology, you understand what can happen, you can pull them from the brain. And he thought about it for a little while, and he said, well, Quan, if you really like that kind of stuff, don't do critical care medicine, do cardiology. And just like that, I flipped. And you're going to find that in your life. Right now, it's so important, like, what's going to be my major? Am I going to do engineering? Am I going to do biomedical engineering? All this stuff. You're going to find out when you talk to your parents, you talk to well, most of you don't talk to your parents, but if you did talk to your parents, you're going to find out where they started is very different from where they ended up. I started off wanting to be a lawyer and maybe an actor, right? And then I ended up doing almost the polar opposite. So I went into the Mayo Clinic telling everybody I was going to do cardiology. But I wasn't going to be invasive. I was going to be a pure medicine guy. I wasn't just going to diagnose, I was going to do this, and then I changed my mind. I flipped to become an invasive cardiologist. Okay? And we're going to talk about that. Now, in order to be a doctor, you have to do 4 years of med school. Then you have to choose your specialty. Now, I just said I was going to do cardiology. Why did I do internal medicine? In order to be a cardiologist, you have to do 3 years of residency in adult medicine, which is internal medicine. After that, if you choose to become a subspecialist like gastroenterology, allergy, or something like that, then you do an additional 2 to 4 years. The hilarious thing was when somebody asked me why I don't want to be a surgeon, is because, oh, I'm a little scared about the high risk nature, and surgery training is just way too long. I literally chose the longest training program you could do. So the things you think you're going to do are not end up being the things that you end up actually doing. I was going to go through this. I don't think I have time, so we're going to go forward. This is a talk that I give to high school students for Stanford. Go forward. So why did I choose cardiology? Well, I love studying the physiology of the heart. The heart's probably could be considered the hardest working organ in the body. Think about this. Think of a pump, a mechanical pump that works for 80 to 100 years without maintenance. Very little maintenance. And all you have to do is feed it cheeseburgers and kale, and it works. It can convert almost any energy source into the energy source that you can use. Okay? Now think about how often the motors on your robot fail. The average human heart beats 72 times a minute, 100,000 times a day, 3.5 million times a year. During an average lifetime, it'll pump about 1 million barrels of blood, enough to fill 4 super tankers. So why choose cardiology? Well, heart patients can be really sick, and you have a real chance to help them if you work quickly. Have you ever heard the phrase, serious as a heart attack? All right, so this is what we call a myocardial infarction, which is just a medical term for a heart attack. Let me just see if I can get, All right, so this is the heart, this is the muscle of the heart. You can see here, this is what we call the coronary arteries. And you can see blood flowing through the coronary arteries. Now if we zoom in a little bit, you can see a little bit of McDonald's, a little Chipotle forming right there, a little Wendy's. Anybody eat at Wendy's anymore? As you see the plaque starting to form over time, eventually what might happen is a little bit of the plaque might break. When the plaque ruptures, we call it plaque rupture, and it'll explode into a clot. And the reason is it releases factors into the blood that cause clotting. And when that happens, you have a myocardial infarction. Now, there are different kind of myocardial infarctions, different kind of heart muscle problems, but it's called a myocardial infarction because once you occlude the flow, the muscle downstream starts dying by the minute, okay? The longer you wait to fix that, the more likely the patient will have either permanent heart muscle damage or they'll just die. And it used to be the only way to fix this problem was coronary bypass surgery. Now, coronary bypass surgery, this is how coronary bypass surgery works. Usually you have an artery and blood flows down it. Now, I love my Pixar type animations. So I figured this how to do this overnight like 10 years ago when I was first trying to figure out how to use Keynote. And obstruction stops the flow. So if you have an obstruction stopping the flow, no flow. What can you do? So what bypass is you essentially build a detour around it. So instead of worrying about the flow going down there, you go around the flow. Very exciting. I really should have gone into Pixar, I know it. So this is what bypass looks like. So essentially, look at the little shaded areas in green. Instead of going through there, you build a bypass around it. Or if you have a little shaded area of green here, then you build a bypass around that. So pretty cool. Except, is there another way? I mean, couldn't we just move the blockage? This is how I figured out how to use the flame effects. All right. I mean, if you think about it this way, if you have a clogged toilet, how do you fix a clogged toilet? Do you build another pipe around so that the toilet is unclogged, or you just clear the clog? So this is kind of in a way that we do it, at least the modern approach. An interventional cardiologist does it. And what we do is we go through a vessel in the leg, we numb up this area around the groin area, we go all the way up, and we put a long straw up to the vessel of your heart, and then we inject a dye into the vessel of your heart. And you can see on the right side of the screen, I'm taking an X-ray at the same time, just so I can see what the narrowing is. And you inject the dye, and right here you see narrowing. Okay? What do you do about it once you've seen the narrowing? You thread a wire across that blockage. That wire acts as your rail. Once you have the rail across the blockage, you then thread a balloon across the wire. That balloon is then inflated, and we call that angioplasty. Now in past, angioplasty was all we had. And 40% of the time, the vessel would just recoil. You balloon it up, and it would just recoil. So somebody came up with the idea of taking the balloon out again and placing a wire mesh called a stent to hold the vessel open. And when you do that, only 5% of the time would you ever have a problem with that vessel. Very cool. So you inflate the stent into place, deflate the balloon, and the stent is left in place. Okay? So people have asked me, well, Dr. Nguyen, what is the difference between an interventional cardiologist and a cardiothoracic surgeon? Okay? And it used to be the interventional cardiologist was the underdog. Okay? Cardiothoracic surgeon said, look, you're doing these procedures where 40% they come back. Well, an interventional cardiologist likes to, a cardiothoracic surgeon likes to solve problems with a scalpel and cutting up in the chest. An interventional cardiologist likes to treat things with medicine and stents. Okay? So, this is an example. This is a 53-year-old guy, and he'd been having chest pain all day, all night, but he thought it was just a little heartburn. He said, and he wasn't going to do anything about it. It'd been like 4 or 5 hours, and then he called his wife, and his wife said, what's wrong? He's like, oh, I don't know. I had some lox and bagels and chili peppers, and now I'm having really bad heartburn. It really hurts. She said, what, you idiot, go to the hospital. It sounds like a heart attack. And this, my friends, is why married men live longer, okay? People don't pay attention to their symptoms, and you need an objective party somewhere else to tell you something might be happening. So I looked at his EKG, I said, oh, you're definitely having a heart attack, we need to take you right away. So we injected his vessel with some contrast, and what you can see here, that's the long straw that I put inside his heart, and I'm injecting something. Now you can't see what's going on here, and I'm going to show you something is missing. Right there, you see, like the flame effects? Right there, you can see it's a little point, something's pointing right at the arrow, like a little, almost like a little bird's beak. That is the occlusion. There should be a vessel right here, and it's missing, it's occluded. So what we did next was we went and threaded a wire across it. So this is before we thread the wire. And you can start to see, as we're threading wire, you can start to see flow coming down the vessel where there wasn't any flow before. That's because the wire is actually starting to dislodge some of the clot. Once we've got the wire across, you can actually see more flow coming down the vessel. You can see that starting to come down. You start to peek through a little bit. And then we threaded a balloon across it and formed an angioplasty. And you can see the dark spot, that's the balloon. This is after the angioplasty. You can see the flow is now coming down the vessel. Then I took a suction catheter, which is just a really long straw that I used to pull out some of the clot. And now, it looks even better. This is a different angle, that's why it looks different. But you can see this is where the wire is, and you can see flow starting to come through the vessel in a much more prominent, much better way. Now this is me placing the stent into place. Can you guys see the 2 dots? The stent is in between that. I inflate the stent into place. and now I have a successful deployment. And the flow of the vessel is much, much better. So, you guys know anything about Jenny Craig or Weight Watchers? This is before, and this is after. Okay. Now, this is an example of a gentleman who thankfully didn't die. This is somebody who had a heart attack, never came in, and this is how his heart looks. These are the 4 chambers of the heart: the right atrium, left ventricle, left ventricle. You see how well the right ventricle squeezes? Look at the left ventricle. It's like not moving at the top. You see that? And it's ballooned, it's dilated. So he could have looked like this guy. Instead, this is how his heart actually looks. It's much better squeeze, okay? He could have looked like this. Heart's barely moving. Instead, he looks like this. Nice squeeze, good strength, not dilated. So this is essentially what I do for a living. Now, people have asked me a lot of different things. Because this is primarily an MSIT talking, you guys are about science and technology, I won't just talk about my life a little bit. I also talk about what interventional cardiology also does. We don't just do this. I treat high blood pressure, high cholesterol. I see patients in clinic. I don't always deal with dying patients. One thing that we do that we're trying to replace the surgeons. So the surgeons, they have a long training process. Instead of internal medicine, they also do instead of internal medicine, they do 5 years of general surgery, then 2 years of cardiac thoracic surgery. And they're very cool. For example, do you guys know what a valve is? So the aortic valve is the last valve that blood has to exit through to get out of the heart, okay? And it's essentially a door. It allows blood to go forward and not backwards. A lot of valves can either become leaky or they can become really stiff, like a rusty door. And as you age, that's more likely to happen. Like you might hear about grandma who had a really stiff valve, she had to have her valve replaced. What they do is when they replace the valve, they cut open the chest and they essentially place a new valve in its place. It's very cool. They actually cut it out and put a new valve right in that place. And when they do that, they have a much better result. The valve works better. And of course, interventional cardiologists, the way we are, is like, well, can we do that without cutting the patient open? Can we do that just through the leg? Without cutting them, I mean, when you cut open someone's chest, they're in the hospital for a week and a half. They're laid up in bed, and then they're at home for like a month, and they're kind of feeling the pain in their chest for about 6 months, okay? Can we do this with the leg? So instead of doing it that way, what we do is this is called the transcutaneous approach. Oh, I apologize for the cheesy music. It's not my music. What we do is we cross, you can see that very calcified valve that's crossed, a wire across it. Wow. Okay. We essentially break open the valve with a balloon. Catheter out, we thread across this very, very huge catheter. It's almost like a stent, like the stent we put in before. The difference is this stent actually has a valve folded up on the inside of it. And when you place that stent across, the valve on the inside of it opens up like an umbrella. It starts acting as a new valve. I didn't write the music. This is an actual procedure being done, but we do it under fluoroscopy. We don't have this nice computer-aided imagery. And this is it. Let's kind of see the way it looks and it's being ballooned into place, and it works just like that. We won't talk about that. This is a talk I did for some at a Jewish community center. Let's see if we can. Okay, I have one more case for you. Oh, this was a talk I was giving to some elementary school students. So I was telling them, I said, you know, you start off life and you think you're going to go one way, and things are going well, and all of a sudden you feel like, oh, I'm floating in the middle of the air, I'm doing great. And then life throws you a curveball, I'm doing really well, and sometimes, you know, kind of so, I have a couple of other cases, but rather than go through cases, why don't we turn up the lights? I don't want to keep you for too long. So a couple other points. We now no longer go through the leg. We decided that that was too risky to go through the leg. We actually go through an artery through the wrist. So you know when you're taking your pulse, we actually go through that artery instead. We do that because the bleeding risk is far lower and the recovery is far better. If you had a bleeding through your wrist, I could just pinch your finger. This is all the procedures I do except for that last one is done when you're completely awake. So no anesthesia, just a little local anesthetic, a little sedation so you don't get freaked out. But otherwise, people are talking to me. I've had cases where I have the patients in the middle of a heart attack, I'm fixing them, and I finally say, okay, I need you to stop talking right now, I have to concentrate a little bit. So it's actually not terribly uncomfortable to receive these procedures. It is a little bit just because, you know when you go to the dentist's office and you get numbed with the lidocaine, the Novocaine? It's the same stuff we use. So that part hurts a little bit, but after that, I mean, I could be in there for 2 hours, you won't even know anything's happening. I had one guy, when we used to work through the leg and go through the groin area, he was really old. He asked me, Dr. Nguyen, are you doing a knee surgery? I said, no. He said, well, because he felt me leaning on his leg, so he thought that was the procedure. So the procedure is not terribly uncomfortable. Recovery is far better. Patients with massive heart attacks like that, the mortality used to be like horrible. It used to be like 50, 60%, and now mortality is far lower, probably less than 5%. There are smaller heart attacks that we also take care of. We do a lot of preventative work. First-time heart attacks are a lot lower than they used to be, and that's just through medication, cholesterol control, blood pressure control, weight loss, things like that. Unfortunately, heart disease is on the rise because obesity is on the rise, so that's something else we're also working on. I have other parts of this talk that I don't want to kind of go through too much, but what questions do you guys have for me? Any questions?
Okay. So for the stent, what's the material used?
That's an excellent question. It's changed over the years. When they first started, they took a slotted steel tube and they laser etched it. And then what happens when you ballooned it open, it would break and it would become this wire mesh. Unfortunately, those were really hard to use because they were so stiff, right? You can see how a lot of those arteries make turns and torque through it. If you try to push a stiff thing through a tube that's essentially bent, it's almost impossible. So they started changing the materials. A lot of them are made of nickel and titanium. They're actually making dissolvable stents. One of them was kind of a more polymer design that's not very good. We're not using them. There's another magnesium design that looks promising, so we'll see. And there may become a time where the stent is no longer inside you, that actually just dissolves. But most people, their stents, they just leave there. But a little bit of magnesium, a little titanium. The stent designs have been very cool because it used to be, I told you 40% of the time people would come back when you just balloon them. The older stents, it was 15%. So 85% was good, but the problem was plaque would regrow inside the stent. So somebody came up with the idea of coating the stent with a drug that kept plaque from growing. And so that's when we reduced our numbers. So actually stent business dropped, in the last 10 years, dropped by more than 50% because we weren't having to go back and repeat it. So it's pretty cool. Anything else?
A big round of applause to Mr. Nguyen.
I know all of you are engineering. I know one of you was thinking about medicine at some point. One of the things I would say about engineering medicine, so this is only a tip of the iceberg at the advances in cardiology. So one of the reasons I chose cardiology is because it had the coolest toys. It was very, very interesting. A lot of stuff I just talked about only came out in the last 20 years. Imagine what's going to come out. In fact, the thing through the leg, that was only FDA approved like 6, 7 years ago, right? By the time you guys are out, who knows? I mean, maybe almost all of surgery will be replaced. Maybe all of it be through the leg or through the wrist. So it's gotten to the point where the surgeons are actually having trouble finding people to want to go into cardiothoracic surgery because, and we still need them, but most people are going into other fields now. So because, but.
Are you using robots for this kind of surgery?
For my field, no, it's not necessary because everything we do is already minimally invasive. So the whole point of robotic surgery is for minimum invasive kind of approach. But for cardiothoracic surgery, certainly, yeah. My friends do robotics a lot. It requires a bit of training because it's a totally different thought process. The whole point of doing robotics is to have a kind of a very small hole. So a friend of mine does valve repairs. Instead of a big open chest procedure, he makes a small incision here and a small incision here, and he goes and repairs the valve. So most of my valve repairs I send him because he does it, and the recovery is faster. But the results are the same, but the recovery is faster. So that's the one advantage of robotic surgery, is that the holes are smaller. In fact, gallbladder surgeries, it used to be they remove your gallbladder, they have to make an incision about this wide. And now it's a hole here, a hole here, and a hole here. And they do everything through a camera inside, and then they just have like little instruments. So surgery's still very cool.
Okay. Maybe I ask a question if you don't have one.
Sure.
So when you push the stent through, why don't you puncture the vein or the artery that way of moving it forward? Does that happen or how is that protected?
It certainly happens. Not with me though. The equipment is better now. It's a good question. The time is not the stent, it's usually the wire. So if the wires, as they go through, they can certainly puncture through any of the arteries. They can actually tear the vessel on the inside out. It's not a risk-free proposition. The wires are soft, and so they're unlikely to do that. If you think about it, the wire is stiff, but on the tip is very soft. And people ask me, how do I get the wire to go where I want it to go? And I tell them I used to play a lot of Xbox when I was in med school. It's essentially the same idea. You're watching the screen here, you're doing something on this side, and it goes to where you want it to go. So you essentially take the wire tip, and you induce a small bend into like a little 45-degree bend. And as you push it in, you're watching the x-ray, and when you turn it, you can watch the thing turn. And then you push it, and you try to get it. What's really tough is if you have a couple of 90-degree angles, because then the wire doesn't want to do what you want it to do. So there's different wire technologies. If it's like an 80% blockage, I can get it through. If it's 90% blockage, I can get it through. When it's 100% blockage, if it's a fresh clot, I can get it through because it's just going like through butter or something. It just goes through. It's not a problem. When it's like 100% calcified hard rock that's been there a long time, that's when you run into a little bit of risk, like what you're talking about, because then you get the sharper, harder wires, and there's a chance that as you're poking through that hard piece of rock, that it'll come out the wrong side of the vessel. It'll come out the so. Have I had any perforations in the last like 12 to 16 years? I had one wire perforation that resolved very quickly. But I have had friends like, sometimes when you balloon it and the vessel is very calcified and hard, it's not as compliant as you want it to be, and I had a friend who actually just ruptured the artery as it was ballooning. So it's not for the people, you know, I was gonna say not for the faint heart, but that sounds stupid. So, but yeah, it can happen. It's not a zero risk proposition. Go ahead.
Why can't you just take the plaque out? Why do you have to do all of this balloon stuff?
That's an excellent question. So when, in 1978 or 1979, Brunswick was the first one to balloon. And so they thought this was really cool because maybe we don't have to bypass anymore. The problem is 40% time it would recoil. So around the mid-90s, they started coming all sorts of different ways. Okay, one was ballooning and stenting. Another one was taking a blade and started chipping away at it, right? The problem is when you do things like that, there is a risk that you could tear the vessel. At least when you balloon, you're just kind of pushing it out, right? And they actually had this theory in the mid-90s that like certain lesions would need what we call atherectomy, which is removing the plaque, cutting it away. Certain would need rotational atherectomy, certain would need stents. It ended up being stents work better than almost anything. There is something, if you have a lot of hard plaque, so not everybody comes in with a heart attack. Sometimes people just come with a little chest pain. They have a 90% blockage, you fix it on an outpatient basis, they go home the same day. If it's really hard, like there's a lot of calcium, and I think if I balloon it, it'll rupture. Or if I try to balloon it, it just won't give because just no matter how hard you push on it, it's not gonna break open. To give you an idea of what kind of pressures we use, who's in physics right now? So right now we're experiencing 1 atmosphere of pressure, yeah? This is 1 atmosphere, right? So I typically, to break open, I use 15 atmospheres of pressure, so 15 times what you normally would experience. And so you could have rupture at that point. So if you think it's so calcified that it still won't open even after 15 atmospheres of pressure, you can take a diamond tip burr, and the diamond tip burr actually rotates at 150,000 RPMs, and the theory is that what it'll do is because of the speed and the frequency, when it hits soft tissue, it just tends to bounce off, but when it hits something hard, it'll shave it. And so you try to shave it out. So you can do that. It is more risk to do that, but we've done it. We do it. We don't do it as often as we used to because we found the stenting was so much more, it was faster. You balloon a stent and you're done. You're done in like 30 minutes. So when you take out the diamond tip burr, the whole cath lab goes, because then we have to take out the gas canisters and we have to take out the equipment, and it's a little bit more work. But we also have laser atherectomy, which is really cool. So you can debulk something using a laser. It is a little bit more work. You have to wear the special laser glasses so you don't blind yourself. But that's also cool. Yeah. What else? Any other questions?
So now you know why Mr. Nguyen likes motors and pumps.